And I'm in DC today. I just went to an event, Diwali event, so trying to rush and then get started with the event. And welcome to all our RP members. And I want to welcome today's speakers, Bhaskar Raivaram. He's the COO of Medcase, and I would welcome Bhaskar Raivaram to introduce the speaker of the night today. And also, it's a very unique webinar where physicians are looking for all other sources of income, not only financial, but which is related to our professions, but which can be done in a unique way. It's a very interesting thing. When I heard from him, I thought, let me bring this to our RP members so that they can think about it and then see if that is possible. This is very passive income and good for our physicians, especially RP. A lot of senior members are here in the RP, and that would be very helpful to our members. So that's why I thought, let me bring this new unique experience from Bhaskar. Okay, Bhaskar, the stage is yours.
Thank you, Dr. Anupama, and hello, everyone. Good evening. I think we're all in the same part of the hemisphere. We're used to having doctors from all across the globe. That's why I want to make sure in the same time zone right now, or same part of the time zone. So good evening, everyone, and it's really a privilege and an honor to be representing Medcase in front of a very elite group of medical professionals, American Association of Physicians of Indian origin. It's truly a privilege. I know some of you personally as well, but it's truly an honor, and I really appreciate your time in joining us this evening to discuss some of the major innovations happening in the field of healthcare. And Medcase is in the what do you call intersection of that innovation as you speak. So this, let me introduce about Medcase first before I introduce you to the speaker of this evening. I'm going to do a slideshow presentation. Do I have the ability to share? Should I believe? Okay. Let me try. Okay, there it is. So Medcase, who we are as Medcase, what we do and why we do what we do. I'm going to spend a couple of minutes to explain our mission and our vision of the world. So Medcase, we are a global marketplace of clinicians / healthcare professionals. When I say global, I would truly mean it. The reason why we created this marketplace is to provide better healthcare outcomes to the world. And the way we do this is by bringing this amazing group of healthcare professionals to participate in certain projects that are in the intersection of medical and technology, medicine and technology. So as you can imagine, the world has so many people, like about 9 billion people in the world. And there are about 25 million physicians, perhaps, that are serving, whose main purpose is really to serve the health and sickness situations of all these people across the globe. And we know that that's not enough number of doctors. On top of that, what's been happening of late for the last few decades or so, the world has been accumulating enormous amounts of medical data. So when I say medical data, it could be images, videos, text, websites, you name it, anything related to medical information that it's been proliferating, been accumulating, and there has been a race to make sense out of this information. And as part of this information, also there is a negative side of it. That's the main topic of the day anyway. But all in all, there is this whole mission of making sense out of this medical information that's been proliferating across the globe. To make sense out of it, as I said, the people that can actually make sense out of it are the doctors. And there are not already enough doctors to actually serve the people themselves. And now we're asking them to do more on top of that. How is that even possible? So that's where the innovation is happening, where information technology is waking up to the challenge of by bringing in artificial intelligence, machine learning into this whole process of making sense out of this data at large volumes. And in order to do that, in order for the AI machine learning to be successful in that kind of an effort, the real intelligence still has to come from the doctors. So in this whole information life cycle, the real knowledge, real intelligence comes from the doctors at a smaller scale of data. And then somehow it gets extrapolated and applied on top of large volumes of data, and then resample it. There's a feedback loop that's happening. So the machines get smarter and smarter. Doctors keep contributing to that whole process. So this is the whole innovation that's happening in the intersection of medicine and information technology. And Medcase is right in the sweet spot of it. So there are organizations, large part of our customers, you can see some names on the slide here. Large corporations are using Medcase to enable them in this endeavor of making sense out of this medical data. And a lot of it would be non-clinical in nature, in the sense there is no patient diagnosis anywhere. They would be looking at information purely and providing assessment of that. So we have, at Medcase, we are right now in 22 different countries, serving 33 different languages, because the reason why we're in that many countries and serving that many languages is this medical information has no boundaries. It's happening everywhere in the world. It's happening in many parts of the world in different languages. The reason why, there are the consumers of this information in those languages. There are producers of this information in those languages. Hence, it needs to be tackled in those countries by the expertise given in terms of that language as well. That's why we are in 22 different countries serving 33 different languages. We are growing at a very breakneck pace. We'll be adding 14 more countries by end of the year, and maybe another half a dozen languages to the whole effort. So all in all, what's happening at Medcase is simply amazing. And it basically presents opportunities to medical professionals, healthcare professionals that are already serving, but also want to be on this, the growth curve of bringing these two amazing fields together. And that's where we want to present to you today some of those opportunities. But before we actually speak about that or present you about those opportunities, I have the pleasure of introducing my partner here at Medcase. We've been together for 18, 19 months already on this amazing journey. So we've been doing something very significant and influential as far as this particular field of effort is concerned. And without further much delay, I want to introduce Dr. Sarah Adams, who is our senior clinical operations lead at Medcase Health as well, helping us on many initiatives that we are working with different customers. So, Dr. Sarah Adams is a pediatrician by profession. I'm not a doctor, so I can't even make sense out of those titles, but I know the fellow attendees of this seminar today definitely know what those mean. But she is an exceptional medical information specialist in a way. I mean, she's got the whole technology side as well. That's quite truly amazing. So we're going to talk about Dr. Sarah Adams, medicine degree, University of Oxford, pediatric residency, University of Louisville, board certified in general pediatrics, pediatric hospital medicine, International Board of Lactation Consultants, practicing pediatric hospitalist as well, and international medical consultant. So she's got many technological skills as well, which are not even listed here. So given that background, it's my pleasure to introduce Dr. Sarah Adams, who's going to talk about how do we fight misinformation, especially during COVID-19, some of the best practices. Dr. Sarah Adams, over to you.
Thank you so much. I'm going to take over sharing the screen. I think it'll just be a little bit easier if I click through myself.
Sure. Sarah does that. Do we have any questions for me? You can ask at this point, but we can also have a quick Q&A at the end.
Are you all able to see the slide?
We can see the slides, yeah.
Perfect, great. Okay, so I'm going to talk about three main topics today, all around misinformation, specifically as it pertains to COVID-19. And we're going to start off by taking a little bit look of just the size of the problem, who the stakeholders are, and how misinformation affects all of us. Then talk specifically about the COVID-19 infodemic. What does that mean? How can misinformation be a pathogen? And then finally focus on actions that we can take to fight misinformation at all levels in our communities and in our professional lives. So obviously COVID-19 has generated a large amount of global interest, right? There's this really interesting website you can go to, Google Trends. So you can search all kinds of terms and find out how often this term has been searched on Google over whatever period you want to look at. So super interesting way of looking at where interest has been. It'll even show you what countries it's been in. So as you can see, news is just a frequently searched term. If you look at the top 20 or 50 search terms, we're not really Googling for information most of the time. We're Googling to prevent ourselves from having to type in a link, right? So the top terms that people actually put into Google are like Gmail, email, Facebook, news, weather. We just don't want to have to find the link ourselves, right? So news is just here as a kind of a baseline of search activity. And then you can see right at the beginning of the pandemic, we just have this gigantic spike in the search term coronavirus. And then it over time kind of gets replaced by the term COVID as that became more known. And you can see it kind of ebbs and flows as different things come out. We could do the same thing for the term vaccine. You can really see when all that interest came out. So this is a fun thing to play with. But obviously this is a very global, all over the world, people are Googling and searching the internet and reading and talking about this. Just in 1 month, a study showed that there were 361 million YouTube videos just on COVID-19 uploaded in 1 month, just to get a sense of just the size of this, right? 550 million tweets on COVID-19 and its related terms in March 2020 alone. And we know that the speed at which articles with false information spread is about 7 times faster than that at which articles with good information spread. So combine those numbers and then the rate of spread that's just slanted towards false information, and you have a huge worldwide problem. So when we're thinking about who is an actor in this, who is affected by this, there is this tendency to think, okay, well, we have the actors, the people who consume information, we're going to be affected by misinformation, individuals, healthcare professionals who are dealing with the misinformation of the patients we're speaking with, healthcare entities who are trying to, make sense of how to be in a pandemic, how to function in a pandemic, businesses, association, governments. And then we have our information disseminators, people who write blogs, TV channels, news organizations, social media companies, internet providers, search engines, all these people that deal with information. But nowadays, in the era of social media, it's a little bit of an artificial division. We're really all both consumers and disseminators of information. If we use social media at all, if we have a business website, if we have a healthcare website, we're all in the process of disseminating and putting out information most days that we interact with the world over online, over the internet. So when we're talking about false news, misinformation, we differentiate between disinformation, which is the deliberate spreading of false information. This is in bad faith, purposefully spreading content that you know to be fabricated or manipulated. And then we have misinformation, which is the well-meaning spread of disinformation, or the spread of misleading or outdated information when you're not aware that it is misleading or outdated. Most people who spread bad information, false facts, are doing it in the misinformation area. But of course, there's overlap here because one person could put out disinformation and then a whole bunch of other people could spread that as misinformation because they're well-meaning. They think, oh, this is important. I should tell all my friends and family about this. So both of those together make up the vast majority of the false content that we're dealing with here. So the WHO Director General put out this quote saying, we're not just fighting a pandemic, we're fighting an infodemic. So what is an infodemic? Well, nowadays, information is really easily accessible and is shared to billions of people, and it can spread through the world just like a virus. It can be really difficult for many people to differentiate between trustworthy information and trustworthy sources and those that are not trustworthy. Anyone nowadays can publish information on anything and reach tens of thousands or even millions of people with that information. So information really becomes very much a pathogen. And it's not just because we're sharing bad information. There's actually technically specific things that encourage the spread of this negative, bad information. One of the reasons is that all of the algorithms that decide what you see in your Facebook feed, what you see on your search results, what pops up in your WhatsApp, what other people send to you, what you're seeing on TikTok, what you're seeing on Twitter, they all reward engagement. Engagement is people linking to it, people commenting on it, likes, shares. It's all based on the premise that if people are interacting with a piece of information, that means it's interesting and other people are going to want to see it. It's not a bad premise, but the unintended effect is that emotional and soundbite content is much easier spread and shown to many more people than myth busting, which is just more boring and less shareable just by the very nature of what it is. You can create a lot of engagement by creating outrage, fear, and by the positive reinforcement that comes of showing people content that already agrees with their opinions. If I have a very strongly held opinion and you show me content that agrees with that opinion, that's going to make me feel good. Oh yes, I was right. And that is going to give me positive reinforcement. I'm going to want to share that. I'm going to like that. There's engagement, and then that algorithm is going to show that to more people. A lot of these algorithms also are designed to show you similar content. The idea is that, just like when Amazon suggests a book to you, if you liked a book that's similar in the past, you're probably likely to like this book. Same thing with your Facebook feed, same thing with social media. If you've liked and engaged with something in the past, here's some more of it. You probably want to see more of it. As a result, we have these information silos, right? One person's newsfeed can look really different from someone else's depending on what information they've interacted with in the past. And then finally, we also have super spreaders. So some studies have shown that 80% of misinformation on a topic is due to 0.1% of the users. That are just widely sharing and very, very high levels of interaction that those users have with the platform. If a lot of this is news, if this is interesting to you, you might really enjoy this goviralgame.com, which is a game where you can actually try to spread misinformation as a way of learning some of the techniques that are used for people who put disinformation out there on purpose. It's a fun game. It's also a fun way to kind of get your kids, teenagers, students to kind of interact with this and learn something about that. So this is a good information of, right, the positive reinforcement that comes from being shown something that you already agree with. This is what we're talking about here. So what are the effects? Well, we know that the health effects of misinformation about something like the pandemic are global. We're going to affect population health. We're going to affect the uptake of vaccines, the mitigation strategies for the pandemic and how many people engage in those, the political and the economic stability of whole countries. So the effects of misinformation in this context are huge. As a result of the way these algorithms work, not only do we have wrong facts, right? We all kind of, you hear misinformation, you think wrong facts, bad facts. Yes, that's out there, but there's more to it even. There's something called the illusory truth effect. So the more you're exposed to a concept, the more likely you are to believe it. The more you're exposed to a term that you don't know, the more likely you are to feel positive about that term. And they've shown that this is true even when you actually have the knowledge to know that it's false. So even when you have the education to know a certain claim is false, the more often you hear that false claim, the more likely you are to actually start to think there's some truth to it. You combine that with confirmation bias, which is the fact that once you strongly hold a belief, you're more likely to remember and pay attention to messages that confirm that belief than you are to messages that do not. And we've seen that even disclaimers, even corrections or little fact checks that get added to things that are being shared that are incorrect, they can actually reinforce the beliefs in those mistruths. So some of the things that sound like good ideas to mitigate this can have the opposite effect of what we're intending. So this is a really complex area with a lot of research ongoing of how do you combat an infodemic, as well as where we're combating a pandemic. There's also a bunch of things that are special about COVID-19 information. So we can have an infodemic, we can have misinformation on all kinds of topics. But when it comes to COVID-19 specifically, we have this info vacuum, right? Especially early on, we didn't know. We didn't know how it spread. We didn't know if it was airborne. We didn't know how infection was going to be. So there's a lot of unknown answers. As physicians, we have something that's great, but it also hinders us. We really like to make sure that before we say anything, we are 100% sure of it, right? So we usually aren't out there spreading all kinds of crazy theories. We want to have the science and have the evidence before we say anything. But that leaves a vacuum for people who don't have those hesitations to just go on in and give information. And for a lot of this public health information, the first thing that someone hears might well be the one that sticks with them. So the info vacuum can really hurt our ability to later come and give good information. It's also really complex, right? We have a widespread interest now in highly technical information. People are searching for things like, what is R naught? Or what is the efficacy data on the Pfizer vaccine? Like things that in the normal non-pandemic life, Joe blogs off the street would not be interested in reading about that. But now people are, and so news sources are putting out a ton of information on really quite technical, medical, biological research information. The pace at which science is changing during the pandemic has been very rapid. So there's rapid dissemination of new findings. Peer review is not able to keep up with the amount of publishing that's going on COVID-19. It's getting disseminated through the news before peer review ever happens. It's also really difficult, even for highly trusted websites, to keep up with the pace. So even the WHO, for a while after they had updated their guidance on wearing masks, a lot of their FAQ pages continue to show their old guidance. It's just really hard to keep all your websites up to date when things are changing so frequently. That kind of has to do with the fact that this information is really evolving. Once correct information can rapidly become outdated and now be incorrect. And then we have the fact that this is a global problem. So the correct answer can vary country by country. What vaccine is currently in use? What vaccine is approved? Can a pregnant woman be vaccinated? Those answers are different in different countries. And then finally, we've touched on this a little bit, but even trusted sources can be out of date when usually they would be a wonderful place to go to for health information. And some trusted sources during this pandemic have also been politicized. So all that makes it even more complex than usual for people to find good information. So finally, what can we do? How can we take action to help fight against misinformation during COVID-19? So hopefully all of our aim is to provide and amplify accurate, trustworthy information about COVID-19 and its related subjects in language that is easily accessible and understandable. So how do we do it? So for individuals, and this is good information, that we can encourage those around us, those we interact with, to put these practices into place. Seek out trustworthy sources. If you're looking for information on COVID, if your friends, your family who are not medical are looking for it, tell them, look at the CDC, look at the WHO, look at these trustworthy sources. Read beyond the headline. Headlines nowadays are designed not to give a succinct, accurate summary of the article, but to create engagement, right? They want you to click on it. Gone are the headlines that say, you know, I saw a picture shared the other day, end of World War II, Hitler dead. No, nowadays the headline would say, you know, who was found dead, question mark. Click on me to find out more, right? Check the date. Sometimes something was a good article, but it's now a year old, so it's not correct anymore. Check the author. Maybe this is somebody that you've heard of. Maybe this is somebody that already has a good or bad reputation for giving good information. And verify before sharing. So there's this fallacy, and I've seen this time and time again from people in my family who are like, I'm not sure this is true, but if it's true, it's really important for everyone to know. So I'm going to share it just in case it's true. And we really need people to do the opposite. If you can't confirm it's true, it's better not to share it. You can report misinformation. A lot of these social media channels now have policies, so you have a way to report. They might put a fact check on it. You know, different companies have different policies. I don't envy them. They are traversing this terrain of, you know, what's freedom of speech, what do we need to stop, where do you draw the line? But they usually have a way to report it, so we can do that as individuals. Amplify trusted sources. When you see something shared by the CDC, the WHO, your local hospital, a good article that explains something, share that, like it, comment on it. And do the opposite with content that is not good. Even when you correct it, even when you comment on it saying, this is incorrect for this and this reason, you are creating engagement. That's going to drive shares. That's going to drive traffic to that piece of information. What about as healthcare professionals, or if we lead a healthcare entity, we lead a healthcare business, what can we do? Well, for us, even more so, we can publish, we can disseminate true information. We can engage on an individual level in our community. Those relationships that we already have are so important to get somebody to think again on a matter. Are you going to think again on a strongly held belief because someone argues with you over the internet? Probably not. But what if this is your trusted family physician? What if this is, you know, your aunt? That's somebody that you might listen to, you might think again. We can act as subject matter experts, which is what we do for Medcase. We can advise governments, businesses, schools, communities, news, journalists as they seek to put out good information, but they don't have the technical knowledge to understand the exact subject matter they're writing about. We can support research and public health messaging. We need our hospitals and our employers to allow people to go and speak on these things, to allow people to go and put out information about COVID-19. We want them to disseminate high quality public health information materials and to amplify clear and understandable messaging. As physicians, we're really good at translating medical and scientifically technical details into language that we can use with our patients that they will understand, right? So that is really valuable in the context of this infodemic. And then if you're a business, if you're an information vendor, if you are, you know, Facebook or a news company or a large health website, what can you do? Well, you can engage subject matter expert groups for content review. So have people who are experts at this tell you what content is good and helpful. You want to apply consistent quality standards in keeping with the end user's needs and their educational level. And then you can curate information. So we've seen a trend in the some of these large networks labeling content from trusted sources, right? So I don't know if any of you guys have noticed, but I've noticed, like on my Facebook feed, there'll be a share and it'll say, you know, this is a trusted healthcare source. I can't remember what exactly it says, but or it says, you know, this has been flagged for fact checking. Are you sure you want to share this? So a lot of places are putting these kind of things in place. There is some argument to say, hey, if you're not going to remove content because you feel like free speech is important, which obviously it is, what about slowing the information? What about just letting it not be shared at the breakneck pace that sharing is currently going on? And then we can, you know, those players can also make choices in their algorithms that don't only reward engagement, but that reward other things as well. And then finally, when we do provide content review, how do we make sure it's evidence-based? How do we make sure that we're providing high quality content review? So 4 principles that we put in place in our team is that we use a large team that includes subject matter experts from multiple disciplines, specialties, backgrounds, cultures, and language abilities. You make sure that we are up to date with the latest evidence. So we dedicate resources, we dedicate experts to helping our team keep up to date with the evolving evidence and guidelines. If I want a doctor to review some information on asthma, all I need to do is find myself a pulmonologist or a family medicine doctor, and they're going to know asthma, right? But the same is not necessarily true for COVID-19. The pace at which the science is changing is so fast that it outpaces what we have to keep up with in our clinical practice. So a doctor who treats COVID-19 patients, absolutely, they're going to be up to date with what the latest medicines are that we can give our patients. But are we necessarily up to date with the phase 1, phase 2 trials of vaccines? No, there's not any reason for us to do that in our clinical role. So we want to make sure in our team that we have specific resources that are helping everyone keep up to date with those nuances. We also want to make sure we take a global perspective. So we need to put our content review into the context of the target country and culture. We need to differentiate between facts that are facts for everywhere and content that needs to be context specific. So to give you an example, if we have some information about how mRNA vaccines work, well, mRNA vaccines work the same way in all countries. So that information should be the same across the world. But if we're looking at content that says, should a pregnant woman be vaccinated? This is more difficult, because what good does it do a pregnant woman in a country that does not allow her to be vaccinated if I give her information saying that the vaccine is helpful to pregnant women? It doesn't do her a whole lot of good, probably causes her a whole bunch of anxiety. So we need to put the context of that person's country or that person's culture around the review that we're doing. Not to change the facts, but to change what is helpful. And that kind of brings us to the last thing, is we want to make sure that the content we're reviewing gets adjusted to the end user's education, literacy level, and the things that drive their need for information. Whenever possible, we want to make sure that we amplify actionable content, content that tells people what they can do, not content that makes people worried with no action that they can take from it. I think we've all had our fair share of worries in the pandemic, and wherever possible, we want to amplify information that does not amplify the worry, but that gives people actionable information that they can make good choices from. That's the end of me. This is Bhaskar's slide, so I will hand back over to you, Bhaskar.
Thank you, Sarah. Wonderful presentation. I'm going to take an opportunity to, before I even speak about the Medcase opportunities, just connect back, tied back to this presentation that Sarah did just now about misinformation to what we do here at Medcase. And then this is just one example of medical knowledge that doctors can contribute to fighting misinformation at scale. And it's not the scale at which the misinformation is happening in the world, as Sarah described, is humongous. So in order for that to be curtailed or to be stopped in its tracks in a way, you need things to be happening at scale. So that means, there are technology firms or companies that have this capability to influence some of that. So Medcase works with a large number of them to make those things happen. So we bring this, at Medcase, there are multiple different opportunities. So we call them as non-clinical activities, meaning anything that deals with enabling and enhancing, enriching data, medical data from the perspective of the veracity from medical content point of view, providing that to the medical content that is seen and shown. So we work with various customers to make those things happen. And also there are multiple AI machine learning companies, medical device manufacturers who are in their own emphasis on preparing their products, preparing their algorithms to suit the market. And they definitely need to lean on the doctors to make those things happen. So to either enrich their algorithms, to enrich their products, their mechanisms, and all of those things, they need doctors to be participating in those processes. And they come to Medcase for, hey, I need certain specialties of doctors just to participate in interviews with us, just to take on some surveys, just to provide additional insights into the outcomes of a particular AI ML algorithm they have. They may ask you to look at tens of thousands of samples that are either rated or scored by an algorithm that would potentially improve their algorithm, and all of those things will have an influence ultimately in the world, because when those products and services and these algorithms make it out in reality for commercial use, that knowledge is now proliferated and being utilized across the globe. That's pretty much what our mission is. And it's not just about making some side income. I know you guys are totally not motivated about just making extra money. You want to have some impact on the world, which is, I believe, is an opportunity, is a galore of opportunities that we have at Medcase, where you can be part of some of those projects that are very, very influential in nature, where you influential in the sense you can make an impact in the world. So by being part of this project, and then yes, you obviously your talent, your time is very, very important, and our customers that engage with us do pay at the market rates for the doctors, and that we basically transparently pay the doctors for their time and expertise as part of these projects. And just to give you a glimpse, if you go to medcase.health, in our career openings page, there's a clinician opening section that talks about lots of detailed set of opportunities. I just want to highlight a few of them for you. Like I said, the kind of customers we have, they're non-clinical side of things, or large technology companies, medical companies, healthcare companies, medical device companies, and AI/ML companies, you name it, all across the globe, where they have opportunities for doctors with various expertise. One example is we have a medical video annotation and rating project coming up, starts in November. About 5 hours of work of looking at videos, processing what's in the video, but it needs to be done in a language. I never thought in my life, when I talk to the doctors, especially, and for hiring them into a job, the first question I ask them is, do you know Hindi? Do you know Telugu? So that was, for me, it speaks to the kind of things that are happening in this field. So if you know Hindi natively, and understand what's in a video, it could be what you're listening to, and so the video could be presenting something to the audience, and there could be some slides in there that are written in Hindi, or that video could be just a series of text flowing through. So somebody have to understand, to read and make sense out of it. So somebody has with a native language expertise is definitely preferred over someone who just learned it. And the medical field expertise that is required is, internal medicine, family medicine, pediatrics, OBGYN, emergency, with minimum 3+ years of clinical experience. So this is, we're looking at 3 different languages immediately, but Medcase is a preferred provider of the multiple language services for various customers. So we bring in doctors from all over the world. In this particular project, the doctors must be in US, and they must know one of these languages. So I'm looking for 20 Hindi, 20 Portuguese, and 20 Spanish doctors. And this is starting in November. 5 hours a week is a conservative low estimate, because everybody is busy. We just have to manage based on their busy schedule. If a doctor can give me 5 hours a week, again, this from what the customer tells us right now, it's a continuous long-term, like perennial project that keeps going. And we just, whoever can contribute to 5 hours. Again, it's sometimes when you are not available, when you're not able to contribute that time, we always scale it back by saying, hey, okay, you're not available this week, maybe some other doctor will step in for you. We take care of all that. Medcase will manage doctors' availability and delivery of the project. So we understand and appreciate the fact that you guys are very busy clinicians, and your time when it comes to contributing to these projects is very well managed by Medcase operational teams. So we will work with the customers, we'll work with you to make sure you're able to get to the work that you need to do in a very efficient and effective manner. And of course, we manage your schedules and work everything around it as well. So there's a fantastic opportunity. It pays by the hour. You just have to be independent consultant with us. So being part of our marketplace just opens up these opportunities. Being part of the marketplace costs you nothing. So what I will do is I will give you an URL where you can actually fill in your information so you can be part of the marketplace. Like I said, it costs you nothing to just become a member of our marketplace, but that also allows us to bring you these opportunities in a very rapid manner, and then also talk about. So for example, I cannot tell you the name of the customer right now who is asking for this medical video annotation. But if you're part of the marketplace, you're already under non-disclosure. So I would be able to tell you, oh, this is this customer that probably will be more exciting for you than just the opportunity. Just having a name, some of the customers are very significant contributors in these areas. So you would be excited to know those names and be part of those kind of projects. And that's one of the non-clinical work that we have. There are many numerous interview surveys and data enhancement projects that are in the catalog of available opportunities. And then also there is the clinical side of it, which is, as you know, during pandemic, what happened, the telehealth as a platform has actually gotten back into the foray with the fact that there's lockdowns happening. It's hard to visit, but then care must be still delivered. So a lot of people leaned on to telehealth platforms. It's kind of forced into it in a way, like just like people are being forced into being part of working from home, even though they were not even situated for it, they were forced into it. So that's what is happening in a way. In my view, telehealth is back in the momentum. There are a lot of telehealth providers now are able to sign impressions into their platforms, and also they're able to. They're basically looking for doctors to now service on those platforms. What we do is we be a conduit on finding. We have a lot of telehealth customers in our relationship, and we want to bring you those opportunities. So one of them immediately would be, somebody who is a primary care physician, either a nurse practitioner, family nurse practitioners, any one of them with a DEA license. So there's a ton of things happening around mental health. Somebody who is able to prescribe controlled substances, if they have capability to do that, there is an opportunity to participate. It's near full-time opportunity. I know we need to hire doctors into a full-time window, but we will be accommodating the schedule of the doctors to participate either in 4-hour increment or 2-hour increments and things like that. So there is another major telehealth provider with these specialties I mentioned here, like endocrinology, pulmonologists that need to participate in some of the telehealth opportunities. There are multiples like this that you guys can participate in. So we'd love to bring you many of those through the communication channels we have at API. And then also, like I said, go to medcase.health and visit our opportunities page. You can always browse through that. I will also set an email out here for you guys. You can just email careers@medcase.health. And I'm putting my email address as well, bhaskar@medcase.health. So just shoot an email if you don't want to fill in any forms. Just shoot an email saying, "Hey, I heard your webinar at API. I would like to learn more, or I'd like to stay connected." We can immediately respond back to you. Please kindly communicate through that mechanism. So at this point, this is just few examples of the opportunities we have. More than anything, what is happening at Medcase is very, very exciting. And it's not just making side income, but making a humongous impact in the world by being part of these amazing projects that we have going on with Medcase. So I would love to welcome all the API members to be part of our marketplace and take advantage of this wonderful healthcare industry transformation that's happening. So that concludes my presentation as well. I would love to take some questions now.
Thank you. Thank you, Mr. Raivaram. So it's a new thing. I don't think any of our physicians have been doing this kind of service. And if anyone has any questions, please raise your hand. And Vijaya, if you can unmute our audience as well. And Dr. Adams, thank you so much. You just presented the reality of this is a one time in our life. A pandemic happened and so much information out there, misinformation. So it was an interesting talk, but it's true that, yeah, this is what is happening. But hope we have some better days coming up. And anyone has any questions, please feel free to ask the questions to Mr. Raivaram.
There is a question here that says, do we need active medical license in any state? For the telehealth opportunities, yes. If we have a compact license, makes it easier for us to, you will pretty much cover 20, 30 states, I believe, for a compact license. But yes, definitely need to have a license in that particular state. Yeah, we have a list of states as well. I can provide you more details for the telehealth opportunities, which states they're looking for. And yeah.
This is Dr. Bhagia from Charlotte. Anupamaji, thank you for this opportunity. Dr. Adams, usually I do telehealth virtual for local hospital where I've worked 15 years and I work at the V also. We do not recommend prescribing controlled substances on telehealth platform. So, and is this mainly for mental health? I would really caution all the doctors in doing this because you should not be doing telehealth.
Yeah, I am not involved with our telehealth branch, so I'll have to turf that question to Bhaskar.
Yeah, it's definitely not for everyone, for sure, and we're very much aware of that. Again, this is just from when it comes to telehealth, even Medcase, we are not assuming we are just a conduit for those projects. For the non-clinical projects, we are very hands-on delivering them. So many telehealth opportunities, we just bring them to our doctor community, and it's up to them if they want to participate or not. We as Medcase do not take any responsibility of the activities or any medical, liability or risk that comes with it. So telehealth opportunities definitely with just a connection, but non-clinical projects, we are very much involved in delivering success hands-on. We manage those projects, we deliver success to the customers in making sure they're getting what they're intending to do through those projects.
When you said non-clinical, what do you?
For example, if the customer is interested in looking at the medical video rating project I just now described, where the doctors that are certain specialties and certain experience, if they want to, if our customer wants the doctors to review certain medical videos, there is no patient information, there's no diagnosis. It's a matter of looking at those videos, and irrespective of the length of the video, the instruction is to watch it for 5 minutes, make sense out of it, and answer 4 or 5 questions and be done with it. So it is purely training an engine to look at a large library of videos and rank them or do some sort of go straight into the misinformation topic that we just covered. So that one is non-clinical. When I categorize them as non-clinical because you're not diagnosing any patients, but the video itself is still medical data, medical content. You are required to use your medical knowledge to assess that. So the questions will be.
Example of it, or you have any sample?
I don't have it, but as doctors come on board, they would get an opportunity to review that. It becomes both ways. So there is a training that happens. You'll be trained on a particular tool, how to look at the video, how do you mark it, how do you answer the survey. During that training period, the doctors can say, oh, this is not for me, or sometimes the doctors may not be the ones that want to do this project. So things like that. So I don't have video examples, but you can think about any Hindi medical videos, for example. You can just go to on the internet and search for Hindi videos. And if it is a medical video that's shown out there, something like that would be presented as part of that. So Though that's an example of non-clinical work. And we've been working on with another large customer to fight pandemic information straight up. And we've been contributing to those projects. And there are many other the AI ML companies that ask us to look at a medical image, for example, and provide annotations on top of it, which will then get fed into their AML algorithm to improve their whatever fine tuning they need to do. So those are all non-clinical projects. Even though you're looking at an image, there's no patient, it's anonymized and such. So we have another large project in Portugal with surgeons looking at laparoscopic surgery videos and trying to provide annotations on top of that. It's again non-clinical in the sense there is no patient data, there's no diagnosis involved, but you're providing insights into a surgical video based on a few instructions that are given to you. So these are all very common data enhancement projects in a way. So it could be audio, video, text, websites, news, articles, you name it. Doctors look at those and provide that info.
Yeah, specifically when we're, for example, offering COVID-19 content curation. So basically clients would ask us to review information that is being put out to the public about COVID-19, and then for us to decide, is this up-to-date information? Is this good information to be published or republished? Is this good information to send people to? And so this is all non-patient care. We're reviewing content in which our medical training is necessary to understand and make decisions. We're not providing any patient care. There's no patient interaction. And then, as Oscar said, you know, when it comes to artificial intelligence, a lot of the ability to use machine learning, it relies on large amounts of data. So we're involved in creating that data. So when if you want a computer to be able to give suggestions on an image search, just like, you know, you can do an image search and it'll tell you what it is. The machine at some point was fed thousands of information, thousands of pictures of something that a human had labeled and said, this is a bridge, this is a dog. Well, we're doing the same thing for medical things, right? So we can review medical images. Radiologists could review medical image saying, here's the heart, here's the rib, this is where the fracture is. It's not for diagnosis. This is not, we're not doing teleradiology. We're not diagnosing that patient. We're just labeling the data onto the image so it can be fed into an algorithm so that that algorithm can later help radiologists make decisions and, you know, show examples of things and that kind of thing.
There are also other opportunities where, you know, they call them UX studies, which is basically a product company or a technology company or a healthcare company trying to do some user experience kind of analysis before they, either as part of their R&D or product development, they want to talk to doctors. So they want to get their real life experiences before they, whatever decisions they need to do as part of their R&D processes. So largely, you know, doctors will participate in interviews. Like they give you 30 minutes time, they get paid for it. And a lot of times the interviews that are short engagements, they pay higher than the normal data projects, for example. But those are the other kind of opportunities we have. So,
Very nice. Okay, any other questions?
Let me see in the chat. There was another question. Do you have teleradiology opportunities, non-clinical opportunities for radiologists? Certainly, yes. Certainly, yes.
Very good.
Yeah, definitely reach out.
This is Dr. Gupta. I had a question. Hello,
Yes.
can you hear me?
Yeah,
yes, Dr. Gupta, please.
Yeah.
Yeah, this is a great presentation. I heard one Dr. Seema Yasmin is from Stanford. She has given very similar information about the disinformation and misinformation. It's such a wonderful education today, Sarah. Really great job.
Thank you.
Thank you, Dr. Gupta.
I think this work, I think it kind of, you know, what Dr. Adams said, that, you know, how much disinformation is being given. So I think these medical experts probably help us to, you know, say that this is how much disinformation is there, you know, is there any disinformation in these video contents and so and so. Excellent work. And anyone want any opportunity on a sideline, I think as a side gig, I think you can look into it. And but Mr. Ivaram, you have given your information, right? And
Yeah, Bhaskar at medcase.health. I just typed it in the chat room as well.
And Api will
please.
have your information as well. And if
Anupamaji.
anything, probably, yes, go ahead.
Hi, Vijay here. Hi, Ravaram. Wonderful
Hello, Dr.
presentation.
Sharma. He's my PCP, by the way. He's been for the last 20 years. Dr. Sharma, very nice to see you.
I know Ravaram very well, and I know Anupamaji, very great opportunity you gave him. And I think this is non-clinical expert opinion to make certain things clear and to give your facts and clinical information. I mean, your expert opinion is not exactly clinical where a medical liability is concerned, I believe. But we'll know more from him. We can contact him. And Ravaram and DFW, if you need some help, we'll be more than happy to get you talk to more doctors or more providers. And
absolutely, I need
you.
Hindi-speaking doctors, Dr. Sharma.
So. I can speak Hindi. And Anupamaji, thank you very much. Great talk.
Thank you.
And congratulations, Ravaram.
And thank you so much to the speakers and listeners. And all right, thank you, and have a good night.
Yeah, I just want to say one thing. What you guys do at API is phenomenal. Being for multiple decades, connecting generations of doctors. I know some of you guys been here for multiple decades in this country, paving pathways for many younger folks to follow. So it's truly great role models, each of you are. And I really commend what's happening at API and how you bring all the people together. I would love to see many of you in person at some of your conferences as well. I happen to be now in the field of medical tech. So I would love to be in front of all of you guys in some of the conferences that are coming up in future.
Sure. We have 100+ chapters in API, and a lot of events happen in the local levels. Yeah, you're happy to, we are happy to connect you to the chapter leadership, and then yeah.
I'd love to. Yeah, I'd love to.
Thank you.
Like you guys have many other doctors in your connections, in your network, please send them your way. We have a very good referral program as well. So your efforts in referring people to us, like I have Portuguese doctors, Spanish doctors. If you happen to know someone in your network, I'm sure you do. Please do send them our way, or any other opportunities. Just send them to our marketplace. We will reward you with a referral program. Thank you.
Thank you. Thanks a lot, and good night to everyone. Bye.
Namaste. Yeah.
Thank you.